Thank you everyone for joining today's webinar. We will be getting started in about a minute. Thank you. Good afternoon, and thank you for joining RadSite's webinar, highlighting imaging quality and performance best practices. Before we begin, I would like to go over a few housekeeping items. Today's presentation will be recorded, and an email containing the link will be sent to all registered participants early next week. To minimize noise and distractions, all attendee phones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using the chat box section on the lower right side of the webinar portal. We will do our best to address all questions and comments at the end of the presentation. I will now turn the presentation over to our moderator, Garry Carneal, President and CEO of RadSite.
Good day, everybody. It's RadSite's pleasure to help sponsor today's webinar, where we're going to be featuring an important initiative led by the National Alliance for Healthcare Purchasing Coalitions and their Evaluate Alliance program, which we'll hear a lot about today. And so today's webinar is really focusing on image quality and performance. And I think you're going to hear a lot of interesting observations and thoughts from our esteemed panel, and how basically after 10 months of meeting, how this is all coming together into a kind of research and RFI initiative that may influence employer behavior or payer behavior over time. So first, let me, again, my name is Garry Carneal, and I'm President and CEO of RadSite. I've overseen RadSite for 10 years, and it's my honor to introduce our esteemed panelists today. I'll introduce them in order of their presentation. First, we have John Miller, who currently serves as the Executive Director of the Mid-Atlantic Business Group on Health. He's held that position for over 20 years, and my hat's off to him. His membership includes Marriott International, Legg Mason, McCormick Spice Company, and many more. In addition, he is the Affinity Chair for Evaluate, which is really kind of the focus of today's presentation. And he is also the chair of the Imaging Performance Quality and Performance Workgroup that put together this initiative. During the 1990s and previous to his job at the Mid-Atlantic Business Group, John held a number of different positions, including one with the Healthcare Council for the National Capital Area, which was a DC Metropolitan Hospital Association. He also served as Executive Director of the Wellness Council of the National Capital Area, which promoted healthier lifestyles for employees and their families. And he also has worked for the Network to Improve Community Health, a nonprofit organization which he founded that helps form partnerships among businesses, hospitals, health insurers, and other stakeholders, really to promote a healthier workplace. And he's a graduate of the University of Maryland. So he'll be speaking first. Then next will be Shiresh Mukherjee, who's a physician. He's a national thought leader and authority in head and neck and neuroradiology. And his primary interests have been focused on investigating emerging metabolic and physiological imaging techniques to evaluate head and neck cancer and to differentiate recurrent tumors from post-therapeutic changes in previously treated patients. In 2001, he was appointed as the Director of Neuroradiology at the University of Michigan, and eventually became a tenured professor of radiology and several other specialty areas. And in 2013, he became chair of the Department of Radiology at Michigan State University. He received his medical degree from Georgetown and his MBA from the University of Michigan. After completing his radiology residency at Harvard Medical School, he attended the University of Florida to complete his neuroradiology fellowship. He's the senior editor of 3 journals and consulting editor for Neuroimaging Clinics of North America and MRI Clinics of North America. He's been the co-investigator of 25 grants, over 260 peer-reviewed articles, and 57 reviews, and 75 chapters and 13 books. Finally, last but not least, we have Dr. Patrick Browning. He currently serves as the Northern California Medical Director for Open Imaging Systems. He's also the part-time Chief Medical Officer for RadSite. Before joining Open Medical Systems, he led the creation of a division of medical imaging for a portion of Sutter Health. He also has served as Vice President Medical Director of Specialty Services at Magellan Health. He has co-authored over a dozen peer-reviewed articles and given over 25 lectures and presentations in US and Europe. And he's passionate about increasing the use of imaging for screening purposes in addition to diagnostic work. He also currently is the Chief Medical Officer for 2 successful automated detection and artificial intelligence startups. Now, interesting enough, his major in college was medieval history before he returned to medical school. I'm sorry, and he received a master's degree in history at UC San Francisco. He completed his residency in radiology and followed with a fellowship at Stanford University Hospital. So we really do have an amazing set of panelists today that are very well credentialed and obviously experienced. Next slide. So in today's webinar, we're going to talk just very briefly about RadSite and the National Alliance, but we're really going to focus on really what does image quality mean and performance in the context of really trying to effectuate change in practice patterns in imaging, and really what payers' expectations are along that way. And part of this is framed through the Evaluate Image Performance RFI, which we'll hear a lot about, and then we're going to have some discussion about next steps and questions. Next slide. So to begin with, RadSite's been around for about 15 years. We are a major accreditation body for advanced diagnostic imaging. We have been in the accreditation space for 10 years. We're based in Annapolis, Maryland. And we have really a fair amount of experience. We've certified over 60,000 pieces of equipment at 25,000 different provider locations. And the leadership of RadSite has been in the accreditation field for almost 25 years and have brought to market well over 20 different accreditation programs. We, in addition to our mission of doing accreditation, we also do a lot of educational programming. This webinar is one example. Next slide. So just to get a little bit more specific, as a context to supporting the Evaluate initiative, we have 3 different accreditation programs currently in advanced diagnostic imaging related to CT, MRI, and nuke medicine. And again, we've been in the business for we've been recognized by CMS under the Medicare Improvement Patient Protection Act since 2013. And after about a 2.5 year effort, we're getting very close to launching 2 new accreditation programs, one for dental cone beam CT and the second for medical cone beam CT, and we'll have some comments about that today. The next slide, please. So part of what we try to do is we try to keep our standards contemporary, and in the next month, we'll be also launching an update to our traditional MIPA accreditation programs, including specialty imaging, and including the cone beam CT accreditation program. And for example, our support of the National Alliance is just part of our commitment and mission to make sure we're helping everybody kind of think through the opportunities within imaging. And for example, another example is our work with now the Radiology Society of North America, RSNA, on their Quantitative Image Biomarkers Alliance. So RadSite's pleased, again, as a sponsor of this webinar. I'm happy to turn it over to John Miller so he can tell you a little bit more about the National Alliance and Evaluate. Next slide, please, Julie.
Thanks, Gary. I will start out with a little bit about the National Alliance, that little logo in the upper left corner of the slide. The National Alliance is a coalition of coalitions. My organization, as Garry mentioned, represents about 25 relatively large purchasers in the Baltimore, Washington area. There are also, though, about 45 coalitions like mine across the country, in Florida, in California, in Chicago, all the 45 of us spread out. Those coalitions collectively represent about 12,000 companies. Those companies, once again, translate into about 41 million people who are represented by the National Alliance collectively through the coalitions, to their companies, to the employees and dependents that are covered beneficiaries of those companies. So that's who we are. The purpose of my coalition, our mission, and this translates to all of those 45 coalitions, is to improve the quality of healthcare that's delivered to those employees and dependents, to improve the health of those folks independently of the medical system, and all at the same time controlling cost. And we believe that better quality healthcare, healthier people, do cost less. So those three things run in tandem. So basically, that's the National Alliance and what we're about, and what my coalition is about as a part of that. Jumping now onto the content of the slide specifically, why this initiative? Why is this of interest to that group? Several reasons. One, medical imaging has been of interest to purchasers for some time, but historically the concentration has been on the cost variation. We've known for a while that what looks to be the same procedure in site A can be significantly more or less expensive than what looks to be the same procedure in site B. So purchasers have been focused on that for a long time. However, we've got new information that, thanks to Dr. Mukherjee and others, but primarily Dr. Mukherjee, that there actually is significant variation in the quality of the medical imaging that's being delivered in those various sites. So we're not looking at a commodity that price variation is operating on. There also is a difference there's variability in quality of that imaging. We also know that there was a low bar of current regulations. Our first step in these sorts of activities as the National Alliance, as a purchaser representative, is to look for third-party accreditations and/or standards that we can go to and say meet these standards. But as looking out there, we didn't find adequate standards in the environment, so we had to create our own. So that's more of the background. We also were drawn to this because of an emergence of market-based initiatives, primarily the most famous one, the one that we're most aware of, that being a partnership between Walmart and Covera that was looking at medical imaging quality, but kind of in a black box. We didn't know exactly what those standards were about and whether it could be scaled or not, and so we needed to go out on our own. I guess the last thing that I would point to is we needed to understand whether or how our intermediaries with the health system, that being primarily the medical plans that represent us, so my purchasers contract with health plans, health carriers, health insurers, and we rely on them to manage the quality of the care that's being delivered. Marriott cannot know anything really about medical imaging. They rely on the carriers they contract with to manage that for them. As we looked into that, we didn't really know how they're managing it, whether they're managing it, and so on. And so, therefore, we put this initiative together, and I'll move on to the next slide. So our method for looking at the quality of what the health plans are delivering on our behalf is an instrument we use called Evaluate. It's been in existence for quite a while. The coalitions have used it to measure how health plans are implementing policies, programs, incentives, outreach that will meet the purchaser expectations in three basic areas. The first one, as I mentioned, controlling cost, also improving quality, and much of that has to do with reducing waste. So basically that's what Evaluate does. It surveys and looks at what the health plans are doing and whether they actually are fulfilling that expectation that purchasers have, that they will manage the quality of care delivered, enhance member health, and control costs at the same time. So the questions that we ask in this instrument provide us with a basic understanding of how good they are at doing that, and specifically in this case, we wanted to know how well are they managing imaging quality. Next slide, please. The output of Evaluate frequently takes the form of action briefs and or runs in tandem with action briefs, and there is one in process right now with regard to imaging. The purchaser community, as I suggested earlier, has been focused on cost as the variable factor in imaging without really any attention to the quality of imaging being delivered. So we're in a basic awareness and education stage with most purchasers now, who will say, oh, wow, I never knew. So we are educating them in that regard, and that output will frequently take the form of an action brief. There is a preliminary action brief in process right now, but we can return to that later after we talk about what the output of Evaluate will look like. There could be subsequent action briefs that will update this with what the plans are doing. The findings of this group may evolve and change the way that we approach this, add more details to it, but Evaluate is a malleable work in progress at all times, and we want to keep it fresh, new, and evidence-based. Next slide, please. So to tackle this problem, we brought together some folks to inform us on what sorts of content we should put into that instrument that we use to query the plans on how they're managing quality, in this case directed toward medical imaging. An excellent group, as Garry has mentioned. We had purchaser representatives. They're on the left-hand side of the slide. Myself, another coalition director, a consultant, a benefits officer from one of our member plans, a medical director from the National Alliance, all representing the purchaser perspective. We had the perspective of radiology experts, including Dr. Mukherjee, Dr. Siegel, Dr. Browning, who you'll be hearing from later and has already been introduced. We also, though, brought in members of the industry to make sure that the output of this group would be challenging but realistic. So we looked at, will it be meaningful for purchasers? Is it scientifically correct? And are the standards challenging yet meaningful? So next slide, please.
Great. So Dr. Mukherjee, if you could kind of help us frame the discussion and how it kind of ran related to quality and performance, that would be great.
Great. Thank you very much, and thanks for having me. Part of the challenge is when you really start to talk about quality, it's really hard to get a consistent definition. So when I look at healthcare, I always divide it into the 6 Ps, and these really, for me, are the components and the stakeholders when it comes to those individuals in healthcare. And those 6 Ps are the patients, the physicians, the payers, the purchasers, the policy, and the politics. And in my role, at one point, I was head of the CON commission, Certificate of Need Commission for the state of Michigan. We had various stakeholders around that table, and eventually, how you can develop and drive consensus is try to figure out what we all want out of healthcare that we can all agree upon. And one of the things that we all agreed upon was we all wanted quality. But the challenge when those people are around the table and individuals that represent the 6 Ps around the table, we all want quality, but it's really hard to come up with a specific definition of what quality is. So as a result, everyone's interested in quality, and eventually the way things have moved over the last 10 years, especially when you look at value-based payments and quality incentives, is that quality has to be something that has to be measured. And this type of measurement can be done through a process, it can be done through a structure or some type of outcomes. And if I go to the next slide, the type of sample performance measures that really form the basis of quality payments are measurable metrics. And those metrics may not be applicable to all of those individuals except for the physicians and the patients. So for instance, this is an example of one of the diagnostic imaging measure sets that was created by one of the radiology societies, and numerous radiology societies are contributing to these quote unquote quality measure sets and quality initiatives. And there are literally hundreds of them, but the challenge is that how really applicable are there, especially to those stakeholders that are actually have to foot the bill for healthcare, and those stakeholders really are the payers, the purchasers, and the people in the government that are having to pay for this. So putting this all together, what we wanted to try to do was come up with some type of quality measure that we could all agree upon, because the typical measure sets are really focused on just one or two of those stakeholders. And one thing that I'll emphasize that John said, and it really made me feel that we're making headway, is that if you ask physicians as to what really drives purchasers or payers, people, the physicians will say, well, they just want the lowest cost that you can get. Well, one thing now that, as John mentioned this, is that costs are important, but what we hope to convey to the payers and the purchasers is that radiology is not a commodity. Radiology has different levels of quality, different levels of value, and what we would like to do is educate not only the purchasers, but everyone on this webinar, is that there are different ways that we can objectively define quality that eventually will improve the overall value of healthcare and eventually result in better outcomes.
Great. Next slide, Julie. So Dr. Browning, as we begin to think through all the components and independent variables associated with quality and performance, and making sure, kind of transcending the notion that imaging is just not a commodity, as Dr. Mukherjee just said. You've spent most of your time being an active radiologist and working for startups, but you did have a couple-year stint at working for a payer. So I thought it'd be good for you to kind of give us a perspective of the payer in this context.
Yeah, thank you very much for the invitation, and thank you everybody for joining on. I think this is a very interesting subject, and I want to reinforce what both John and Suresh said, which is that, yeah, the payers initially started just wanting to control costs, assuming that quality was all the same everywhere, right? And it's really been through the work of RadSite, Evaluate, other organizations that I think the payers have become much more aware that it is really more than just cost. There really is something to be said for a high quality study delivered, not needing to be repeated, not giving the patient more radiation. There's a lot of good things that come out of quality that initially the payers weren't quite aware of. Don't get me wrong, their primary goal very frequently is still to control cost, typically by avoiding overutilization. But on the other hand, now they're looking at quality as a different way of optimizing the diagnostic ability of that particular study. And so now repeating something, preventing fraud across the country, which I will be honest with you, I have done a lot of leadership and a lot of radiology development over the course of years. And so sort of jumping over the fence and joining a company that was on the payer utilization management side, I was shocked at the amount of overutilization that actually goes on. I hadn't paid much attention to it as a radiologist, but I'm sure that both Suresh and Garry and John can attest to the fact that there is a lot of room to be able to save medical care costs, save patient radiation, do a lot of different things that are very, very positive if we concentrate on quality. And very often that's just doing the right study at the right time for the right patient. There's a lot of ways to do it, as they're listed there. I won't read them off, but there are a lot of arrows in the quiver that I think we can use if we work through accreditation bodies like RadSite, Evaluate, and others. I think the next slide.
Okay, great. So, John, you want to kind of help us set up. So with all these kind of moving parts, what Dr. Mukherjee mentioned in terms of the quality performance, and then Dr. Browning's point about kind of payer and their frame of reference and the concerns of overutilization, but maybe kind of also staying focused on population health. How do we kind of set this up and move forward?
Yeah, well, I think my first step, Garry, is will be to back up just slightly and share that my awareness of this entire subject came through a presentation that Dr. Mukherjee did for a medical directors group that is a subset of the National Alliance. Many of the coalitions and some of the private purchasers have corporate medical directors. That group gets together and talks about things that are of interest to them, and I monitor those calls from time to time because they're also interesting to me. And in one of those calls, Dr. Mukherjee shared a couple of studies that were just whacked me upside the head and revealed to me that this variability in imaging really did exist. As a result of that, I followed up, and Dr. Mukherjee followed up with me, and we began talking to each other about this. This is something that we should put into evaluate, that we should include with the variety of other measures that are already in that tool, that we should be holding the plans accountable for holding the provider community accountable for high quality product. So backing up slightly, that's how that all began. You may notice that I use a lot of plain English language in this discussion. That's because that's all I've got. I relied on folks like Dr. Mukherjee, you, Garry, Dr. Browning, a variety of other folks who really do know what they're talking about to guide us down the right path. But what we wound up with, you'll see on this slide, in my opinion, after months of discussion with this excellent group, there was a long laundry list of things that we could talk about and put into evaluate, but it needed to be succinct and manageable. There's only so much we can put into this. As Dr. Mukherjee sometimes says, the best survey is the one that people answer. And so we had to keep the survey, the instrument succinct yet meaningful. And so all of that laundry list of suggestions boiled down to these basic categories. And I think that they are relatively plain English. The output of this is ultimately going to have to be meaningful to purchasers. Otherwise, we're in the wrong venue for the instrument. But when it is meaningful to purchasers, purchasers can use this information and their purchasing power, their market share, to drive improvement. So that's the beauty of where we are. Those categories wound up being, we boiled them down to equipment, personnel, program, and emerging CT cone information. So it's very common sense. You know, where can this variability occur? It could occur in the equipment. It could be miscalibrated. It could be faulty in some way. It could be that we have the wrong personnel looking at the equipment. It could be that the personnel that is looking at the equipment is not keeping up with each other and honing and sharpening the saw as they go along. It could be, as Dr. Browning pointed out, that the utilization needs to be managed as well. We've historically done that through the choosing wisely format, attempting to empower patients to work with their physicians to manage their own utilization. This takes that a step away from that, I think, and above that, and will be very useful to the purchaser community. And then finally, you folks brought to my attention and made it clear that we also needed to get a step ahead of the game, not just look back, but look forward. Ergo, the inclusion of cone beam CT imaging in the program. So next slide, please.
Okay, great. So before we dive into this, Dr. Mukherjee, I neglected to, in your introduction, note that you also serve as the medical director for the Economic Alliance of Michigan, which is one of the National Alliance member purchasing coalitions. So along your journey as a active practicing world-renowned neuroradiologist, what kind of filtered into your practice to make you start thinking about these questions in a way that, as John alluded to, you had this presentation, or led to your affiliation with the Michigan Employer Group?
Right. Well, no, I appreciate that. I've always had a bit of a restless mind, and I've always wanted to see what was on the other side of the mirror. So as a practicing radiologist, and especially in academics, you sort of get tunnel vision into one thing. But, you know, part of the way I'm wired is I've always thought when you get around the table and people have different opinions, there's probably a reason why people are saying what they're saying. And in general, if we believe in the goodness of the human spirit, there's probably a reason why people have different perspectives on healthcare and how it should be funded and what their definitions of quality are. So as we sit around this table, oftentimes we'll have discrepant views. And so part of my journey was to try to really understand different people's perspective when we talk about healthcare. So that really led me into some of the more administrative aspects of it. There's an old saying, be careful what you wish for, it may come true. And I've always had the good fortune to do jobs nobody wants. And if you do a good job nobody wants, the next thing you're going to be doing that job for a long time. And so as my journey has kind of happened, I got involved in the Certificate of Need Commission. I got involved as chair of that commission. Then I started working a little bit with the Economic Alliance. And as John mentioned, what's really reassuring to me is that purchasers don't mind paying more for healthcare services. And what John said, again, really makes me happy in the sense that there is now an acknowledgement that there's different levels of quality. And I think purchasers don't mind paying more so long as they know what they're getting. And they just want to make sure that if they're going to pay a little bit more, they want to make sure that there's a certain standard or a threshold of value. And I think that is something, which part of one of those P's you're coming from, that's something we can all agree upon. That you're willing to pay a little bit more, but you want to make sure there's a certain threshold of quality and value that you're receiving as a patient, and as a purchaser or payer, you want to make sure that there is value for that extra cost that you're putting into the system for your employees.
Great, thank you. So Dr. Browning, as the discussion has proceeded, we have this ecosystem of process, structure, and outcome measures. One part of imaging is the equipment itself. And for example, part of the Center for Medicare and Medicaid Services requirements, there's a technical component for accreditation where you actually have to evaluate the equipment. So it's kind of this part of this larger ecosystem. Tell us a little bit about the annual physics testing and reporting questions that the Evaluate Workgroup came up with.
Absolutely. And first, I just wanted to reiterate and agree with what Suresh was saying. I'm being on the payer side. They're like everybody else. They just, if they're going to pay more for something, they want to know they're getting sufficient quality and return on investment. So, and I have seen that personally. So it really has changed from just a purely cost measurement program into something that's more broad. And I think as we continue to work on increasing the broadness into quality and other measures, I think that we'll continue to go that way. One of the things, obviously, that does contribute to quality is going to be the seventh P, physics. And that's important because low quality equipment will typically not produce very high quality results. It will end up with over imaging. It will end up with misdiagnosis or non-diagnosis, or any number of things go down the road of poor equipment quality. I think that having been in a good academic institution, I know Suresh is in a great academic institution, we get used to this idea that quality is just always there. I was very surprised to find out how much variation in quality there is across the country, especially when it comes to physics. Physics is relatively complex. It's hard to keep a handle on. It's hard to really pay attention to routinely because it sort of sits in the background. You don't worry about it much until it gets really bad. The images tend not to look terrible. But annual physics exams and doing other maintenance work for the equipment is very important, both because of the quality of the images and also making sure, as we'll see a little bit later, that the patients aren't being over-radiated or subjected to additional imaging they don't need. So much of the work we do is doing at least annual, doing routine internal physics testing, ongoing, and calibration testing is incredibly important. And even to the point of doing a daily phantom test for the CT scanner, if it seems even close to out of spec, or even just doing it routinely, is incredibly important. And so I've been very happy with the fact that RadSite, Equate, other or Evaluate have been really good at making sure that the physics of the quality have been paid attention to, not just necessarily turnaround times, report structure, other things like that. And I think that Suresh will talk about the personnel, which is incredibly important, harder to quantify sometimes and sometimes more delicate, but I think the personnel, the people performing the imaging and the people interpreting the imaging are exceptionally important to pay attention to, as I'm sure he'll mention.
You know, it's been interesting because having RadSite does require a physics report to be uploaded and evaluated by a physicist as part of the review process. And to your point, Dr. Browning, the variability is very surprising. And I think part of that also, in terms of the underlying physics testing requirements, is inconsistent between accreditation bodies, between payers, and between regulators. And I think, John, I think one of the strengths of this initiative is that it's actually creating a conversation, a dialogue about a baseline standard that should perhaps be more uniform. When you think about your car, right, you take it in, periodically to get tuned up. Some states require that you have your, exhaust tested. Imagine not ever testing the imaging equipment for issues related to patient safety or the fidelity of the exam. And when you get to advanced diagnostic imaging equipment, you have a lot more literally moving aspects in terms of what that exam's going to do in terms of the diagnostic. And, basically, if you have a machine that's not calibrated correctly, or you have the wrong person operating that machine, there is potentially patient safety issues and certainly clinical efficacy issues. All right, so let's go to the next slide, Julie, and talk a little bit about the clinical peer review process. Dr. Mukherjee.
Yeah, thanks a lot. I just wanted to, Garry used the term threshold. I just wanted to emphasize that to the audience. Again, if I look at my scientific mind, I look at everything as a bell curve. And basically, the median of that bell curve is quality. And what we want to do is that we want to push the bell curve to the right. And there are different ways of doing that. You can take the highest performers or make them higher performers. But by doing that, you're going to get a lot of pushback saying that we're already spending multi-million dollars of equipment. We have the subspecialty radiologists, so on and so forth. The other way to move that mean to the right is if you look at that bell curve, it's really to try to eliminate the lowest end of that curve. And by doing that, you achieve the same thing. You push quality to the right. So what we're doing is we're not focusing on people that are already doing a great job. We acknowledge that. And so for those that are doing a good job at the high end of the bell curve, that's fantastic. Kudos to you. Keep doing a fantastic job. You're what we all aspire to. But as we go through this process, what we're trying to do is that you would be surprised of this large variation in what people are doing. And we're trying to eliminate the bottom 5 to 10% of that curve. And the people at the high end of that curve are probably going to be okay with it because the bottom end and the high end are still taking care of patients. Probably their revenues and their contracts are the same. And they're probably saying, why am I spending X number of dollars and receiving the same reimbursements when someone that's not putting as much effort in it is doing the same thing and getting reimbursed at the same rate? So that's part of the strategy of what we're trying to achieve. So a lot of the things that I'm going to talk about just from a pure clinical review process, when I talk to radiologists, it's almost like a duh. Well, of course we're doing that. But you'd be surprised what's out there. So in a way, for me, just like John, I'm a pretty simple guy. I'm sort of a Fred Flintstone approach to these things, but it's sort of common sense. So when we look at the clinical peer review process, all we're asking payers and purchasers to do is to ensure there's a process in place to promote consistent and evidence-based decision making. So specifically, do you require your clinical services, those radiologists that are interpreting studies, to participate in some type of peer review process? And peer review means is that you have a group of people that intermittently review studies that one radiologist looked at and see whether or not they agree with them or not. It's a very simple process. Every institution I've been has had one. I had one when I was a division director. I had one when I was chair, and now in my current practice. And all we're asking you to do is ask that question. And if the answer is no, well, you sort of have to be careful, because then you say, well, why aren't you in a peer review process? But if the answer is yes, just say, are you participating in the American College of Radiology's RAD Peer program? Is it some type of modification of that process? Is it a peer review process that is part of your electronic health system? Specifically, when we do voice recognition, some of these systems already have a peer review in there. Is it some type of your own internal process? Or is it some kind of missed case conference? We're not saying any of these 5 are right and wrong. All we're doing is just ask the question. are your providers in a peer review process? If it is, what are they doing? You don't have to say what they should be doing or what they shouldn't be doing. Just ask that question. So very, very important, but really a simple concept that all of us should be participating in.
Great, next slide. So way back in the day when managed care first came on the scene, Dr. Browning, in the late 1980s and early 1990s, pretty much all 50 states, with a few exceptions, adopted utilization management protections. So did the federal government. And it started off by kind of making sure managed care organizations have a structured process to determine what's medically necessary and appropriate. I think we've already made some comments that at some point it became more about cost than anything else, but obviously patient clinical efficacy is a big part of that. So tell us a little bit about what we're doing with utilization management with this initiative.
Yeah, I think that that's a great sort of short history about utilization management. For sure, when it first came on, it was there purely to control costs, and denying necessary studies was the best way to do it at the time. But I think it has matured quite a bit. I think that one of the things I'm most proud of in my work with my prior organization is that we made sure all of the guidelines were absolutely supported by peer-reviewed literature. And I asked all of the reviewers to ensure that they were adhering to the guidelines. Situations occurred in prior utilization management companies where they were based on some sort of sliding scale depending on the types and amount of denials. And so they were just basically asking their reviewers to deny anything that seemed even mildly suspect, regardless of how necessary it might have been for the patient's well-being. So sort of along the lines of what Suresh was saying, we created sort of a peer-reviewed process for the reviewers and for the guidelines to ensure that we're delivering consistent quality care. I think it's important for companies like RadSite Evaluate to make sure that the utilization management companies or the payers that are involved in imaging in a particular facility understand that, adhere to that, and make sure that they give the best patient care they can, not simply sort of deny a study because it's too expensive or delay approval for a study that's required for patient therapy or anything like that. I think that our ability to ensure that those sorts of principles are adhered to is a significant part of the whole process and very important. Next slide. So utilization management, I'm sure everybody on the screen is familiar with the whole process. It's way more complex than I ever would have thought. As a radiologist, I mean, I was at the very end of the whole process. I just read the studies that came in the door. I didn't worry too much about how they got approved or whether or not they were approved. I basically just wanted to fill up the schedule and give the best care possible to the greatest number of patients. But as you can see, utilization management has changed quite a bit for the better, especially, as I said, the evidence-based clinical review criteria, making sure that we're monitoring referring clinicians and catching any sort of unusual referral patterns. I can tell you one quick story. There was a radiology group in a particular part of the country that was insisting that the clinicians order non-contrast abdomen and pelvis CTs, and then on virtually every patient they were reading those, and then they were recommending the patient get a follow-up contrast enhanced CT. And the reason for doing that was they can then charge for 2 studies, but it was pretty obvious what they were doing, so we were able to clamp down on that. But I'm proud of the fact that actually companies like RadSite Evaluate, the companies we want to make sure we're delivering the best patient imaging care possible and making sure patients are not being overutilized, overradiated, whatever the case may be. This will become important with cone beam as well. It's going to be a pretty ubiquitous type of study. I think it'll be very important to make sure that we're tracking results, we're tracking quality, we're making sure that the facilities adhere to our prescribed quality standards, and, excuse me one second, and that we hold them responsible for that, if you will.
Great. Next slide. So Dr. Mukherjee, Dr. Browning, cone beam CT has come up a couple of times. I think obviously this is a case example of innovation within the imaging field. Why don't you talk a little bit about cone beam CT and kind of what the questions will be related to evaluate.
Yeah, so cone beam CT is a smaller CT that's an in-office CT that really hasn't been adopted by different specialties, mostly clinical specialties and some radiologists, but mostly clinical specialties that feel they can integrate this into their practice. And where it's most commonly been integrated are by dentists, some ENT, some orthopedic surgeons, and a few others. But the challenge is that cone beam CT is not really regulated and doesn't really have basic standards that we can all agree upon. And next slide, please. So some of the questions that we should ask about cone beam CT is physics testing and reporting really required for cone beam CT, yes or no? It's a very basic question. And it is important because a lot of the cone beam CTs are oftentimes out of pocket for those patients. So if you are out there and you have to undergo a cone beam CT, you may have some coverage for it, but oftentimes a lot of it is out of pocket. The purchaser should be asking, and the payer should be asking, does the payer reimburse for cone beam CT for the following specialty? Is it dental, ENT, maxillofacial, ortho, or podiatry? So are you paying for all of these or just some of these? And if you are paying for it, again, a very simple question, and similar to what we talked about with CT and MR and some of the other advanced modalities, is are you asking a simple question? Eventually, when it comes to imaging, you have to acquire the images, which is important, but then you have to interpret the images. So from cone beam CTs, I think we all agree that you should ask the question, does the payer require the interpretation of the cone beam CT specific by provider? So for instance, if a cone beam CT is acquired, who is reading it? Is it a board certified radiologist? Is it a physician, any physician, MD or DO? Is it a trained specialist within their scope of practice? Or are there no limitations? And these, again, are very, very basic questions. Because once that study is provided in someone's office, who actually is interpreting it? So for instance, as a radiologist, I'm required to have continual medical education in which I have to stay updated in my field of expertise and within my domain. But when it has a cone beam CT in a clinician's office, they're doing lots of things. Some may be operating, some may be doing just pure diagnosis, some people may be doing procedures, and now they have a cone beam CT. Who are these people that are interpreting it? And just like us as a radiologist that have to have continuing medical education to make sure that we keep up with innovations, are they having the same type of updates in their imaging knowledges to ensure they continue to be qualified to keep up to date regarding their domain expertise when it comes to imaging from their cone beam CT? And then finally, does the payer require the cone beam CT to be accredited, yes or no? And if it is yes, which accreditation program are they using? Is it some IAC dental cone beam CT? Is it RadSite dental cone beam CT, RadSite medical cone beam CT, or some other type? So again, these are just really 4 or 5 basic questions that I think are sort of common sense that payers and purchasers should be asking those individuals that are submitting claims or performing these studies on patients that have CTs within their offices.
It's exciting when you have these kind of developments. You think about a patient, let's say has a knee injury, to get a cone beam CT image with weight on their knee for the additional potential diagnostic fidelity, or if you're going to an oral surgeon to get a full 3D image of the mouth. And it's fascinating when you have the situations where, because it's an emerging technology, there are no national uniform standards for physics. And that's in some respects why RadSite's been taking so long to actually develop the standards, which hopefully will be launching later this fall. So we're really looking forward to that feedback, but I also think it's important. Evaluate here is actually helping create national standards that literally will improve patients' lives, but also make sure patient safety issues or the kind of inconsistent standards are out there right now kind of fall into place, according to best practices. So that's exciting. Let's move on to the next slide. So John, obviously there are hundreds, if not thousands, of different measures. A couple of them didn't make it. We've highlighted 2 here. I just thought you would, obviously talk a little bit about the process of what Evaluate can and cannot do, and obviously how we narrowed the scope, and certainly defer to you in terms of some of the topics we talked about or the measurements that didn't make the final cut for this particular survey.
Yeah, and I'm not going to belabor these really, Gary. But before I do, actually, I'd like to go back to the cone beam imaging discussion that Dr. Mukherjee just shared with us, and not in detail, but this was one of the whacks up the side of the head that I got. That actually this isn't already a standard of care. That these expectations are not already in place. That the health plans, the carriers are not already managing this process. It's just it was astounding to me, and that's part of why I'm so excited about the process that we're finishing up now, and we'll soon be learning more about. So, just to a purchaser, they assume these things are a given. Learning that they're not a given is just really eye-opening. So, thanks for that, Dr. Mukherjee. So moving though on to these last couple of slides here, there were a couple of things that, as I said, there's limited counter space that we have in Evaluate, and we had to pare out some very important things. And I'm most regretful about these things that we've left out here, because they are one of the P's, largely the patient perspective. And it's unfortunate that I'd say this is something that happens in the purchaser world way too much. We're too concerned about the quality of the care and the cost of the care, and not as concerned about what it really means to the poor devil that's receiving this care. So I laud Dr. Mukherjee for pushing on this, and I'm sad that we were not able to include these measures in the final set of measures. But the first one, of course, here is on access and wait and turnaround times. How long does it take to get the results back to the patient? So you're, humanistically speaking, you're the person speaking right now, Achilles tendon surgery a year ago, based on an MRI, and the turnaround time was not too long, but the state of suspense was agonizing. More agonizing almost than the surgery itself. So this is an important measure. This is an important set of measures. I hope that as we drum up more interest around this subject, this may be something that we can insert in future iterations of the Evaluate tool. But I assure you that even though we're not inserting them in the tool, we are including this thinking in the action brief that we are putting out, educating purchasers. So issue number one, wait and turnaround times. Next slide, please. Issue number two, patient engagement. So how engaged are the patients themselves in consenting to an advanced consent? Their involvement more or less in the decision making around this process, and also are the results of the process communicated back to the poor patient in a timely way, in an understandable way, in a sympathetic way, so that the patient is drawn into the decision and the engagement with their own process. So these measures, unfortunately, were ones that were discussed that are important measures, but we didn't have enough space in the tool to actually include them in the measure set. So regretful about that. And I will also, as we move into discussion time, say that it was also extremely impressive to me that we got this group together and put this thing together as rapidly as we did. Normally we're used to something like this going to the National Quality Forum or something, and 3 years later, after 4 iterations back and forth, we finally get a measure that comes out. By that time, half the time it's obsolete anyway. But this did not happen this way. I'll refer to a certain prominent politico's terminology these days. This happened at warp speed. So well done by the group, and I assure you that the purchaser community is appreciative and thankful that we put this together so quickly. So thanks, Gary.
Sure. Well, John, thank you for your leadership as the chair, and Dr. Mukherjee for kicking things off. Dr. Browning and the rest of us who are part of the work group, and I should say our administrator on the webinar, Julie Irons, is also the administrator of the work group. So thank you, Julie, for keeping all this in alignment. Next slide. Before we take questions, John, can you just go into a little bit more detail? Maybe use the example of a previous evaluation initiative like mental health, you pick it, but can you just explain to the group exactly what happens after the RFI is issued, the issue brief, and how it actually kind of potentially changes behavior, or payer expectations?
Yeah, I'll give a very, very specific example that was quick and effective. I'll use the analogy of mental health. We are engaged in a mental health initiative right now across the country and specifically in the Mid-Atlantic. One of the things that we're driving for in the area of mental health is collaborative care. That primary care physicians deliver a lot of mental health services. They are not especially well trained and qualified in that area. It's best if they have collaboration with a behavioral health specialist in that area. It's important for that to happen, though, that the health plans, so once again, the analogy holds true, they are the lieutenant on behalf of the purchasers with that provider community. It's important that the health plans pay for collaborative care. So we've had, as we've begun kicking this off, we've discovered that the plans were not necessarily paying for collaborative care. Through the evaluate process, we learned that. In asking that question, we had meetings with some of the plans. Within 60 days, at least one of the plans had turned on the codes for paying for collaborative care within 60 days. So we can see results come from this, and I would hope that, and we will see that, through sharing with the payer community, the purchaser community, what the state of the art is, what the state of the industry is with regard to medical imaging. We hope that through market share and through market pressure, as Dr. Mukherjee referenced, we can move that bell curve to the right so that we can achieve more high quality imaging, that those that are already delivering it will receive rewards for having delivered it, that those who are not delivering it will be incented to start delivering it. And so this is the way Evaluate can and should work, and I'm looking forward to that being the case with medical imaging as well.
That's great. So Dr. Mukherjee, Dr. Browning, John just described the National Alliance for Healthcare Purchasing Coalition's role with Evaluate to operationalizing a new delivery model that was in the literature, collaborative care, coming out of the University of Washington. And then there were some codes created, and it was Evaluate that played a leading role in terms of activating that, which again, it addresses the deficiency of the mental health delivery system through the primary care. And that model uses a case manager and a mental health professional to team up with the primary care physician. Makes a total amount of sense. So I guess the challenge and opportunity for us with the Evaluate Imaging Performance Initiative is to try to kind of bring some things together really to promote population health in the same way as related to imaging diagnostics. And of course, we haven't talked a lot about radiation therapy, but the question is, what potentially do you think potentially the outcome could be from this initiative in a way that's similar to the collaborative care model? Thoughts?
I'll let Patrick start off with that.
I was just about to say the same thing to you. What actually pops into my head in a collaborative way is I think as we've seen through Cone Beam, there have been other much more portable imaging devices coming online. I'd always sort of predicted the fact that miniaturization would continue. I think that one of the biggest opportunities will be in ensuring that if a primary care doctor or a dentist or an orthopedist or pulmonologist or whomever has a piece of imaging equipment in their office that they use to deliver more rapid and effective patient care, that they are not falling prey to thinking they can take care of it all, and that we can work as radiologists and as radiology facility accrediting bodies to make sure that they understand that it's really important to be collaborative when it comes to imaging and it comes to distributed network imaging like that. thinking that you're an island will not benefit their patients very well. So whether radiologists may work in a collaborative way to just do peer review for those facilities they're interpreting themselves, whether they actually do the professional interpretation. I think there could be any number of different ways, but I see that being increasingly impactful in the future. What do you think, Suresh?
Yeah, I completely agree. I think part of it, I think one of the most effective ways to change behavior is just the Hawthorne effect, and that is
absolutely.
Sometimes you know, if you're just being watched, it changes your behavior. And yeah, I sort of hate to say this because I kind of shoot myself in the foot. The worst thing, the most discouraging thing, some of the most discouraging things that can happen as being a practicing physician is that you have a bad outcome on a patient, or you get sued for something, and you try to make your best effort. But the legal system, the only benefit that I do see is sometimes it does make you think twice. Maybe you'll spend a little bit more time on something that you normally wouldn't. And so when you know you're sort of being watched in that context, I think it makes you, I think, look a little bit harder.
Absolutely.
And I think in a situation where you have a system in someone's office and you own that piece of equipment, and I don't want to pick on the dentist, but you own that equipment, imaging equipment, just like you own the chair that your patient is sitting on. And someone says, well, I use the chair as much as I want to because it's my chair. And someone says, well, I use that imaging equipment as much as I want to because it's my equipment. But when you're actually looking at that imaging equipment, and there is radiation, albeit very low, but you are imaging patients and you are then interpreting that study, then I think just by the fact that somebody's kind of peering over your shoulder saying, well, are you make sure that the equipment is up to date? Is it a 30-year-old equipment or is it a 1-year-old equipment? Yes, it's supposed to have low radiation, but I can tell you some of the older equipment tends to leak radiation, and then who's interpreting that study? And at least if you ask the question, you don't have to change that behavior, but so long as you know that you're being watched, sometimes behavior is changed.
Absolutely, I agree.
That's great. I know we're about out of time. Julie, did anybody, any questions come in through the portal?
Not so many questions, but there were a couple comments.
Okay, great. Well, I know we've actually run up against the hour. We want to be respectful of everybody's time. So this is a discussion to be continued. To me, it's thank you for each of your participation. I do think that this initiative in imaging will have a profound impact, similar to collaborative care. One little vignette is, for example, the cone beam CT. That's used as technology for linear accelerators and C-arms. So in the going backwards, you had one CT and then you had 30 radiation treatments, and the CT was used to position the body organs. With cone beam CT, because it's less ionizing radiation, you can do a cone beam CT for each radiation treatment, so you're more precise in terms of radiation therapy. So there are literally tons of benefits that we're going to see based on building on the comments that you guys just made. So thank you very much. And Julie, we'll kind of close it with you with your final announcements.
Sure. Again, we will be sending out an email to everyone next week with the link to the recording. You can always as well find it on our website, radsitequality.com. So if you do have any additional questions that you weren't able to answer after you think about this, you can always send them to info@radsitequality.com and we will send it to the appropriate panelist. So we want to thank everyone for participating today and hope you have a great rest of the day. Thank you very much.
Thank you, everybody. Appreciate it. Take care.
Bye-bye. Thank you, Julie. Bye-bye.
All right, I think we're offline. Great job, guys. I thought that went really well.
Thanks, everyone.
What were the comments?
Julie, still on?
I am, and I think we're all out of the, what's his name?
I'll check with Patty.
Check with Patty. camera turned off?
Thanks for the kind words, John. I appreciate it.
We need to hang up. We need to hang up, everyone. Bye.
Bye.